Alright, today we're going to be going over Fundamentals Exam 2 Study Guide. We're going to start it off with medication administration and clinical judgment. Then we'll hit up fluid and electrolytes, and finally finish it off with tissue integrity. So, what is a chemical name? Provides the exact description of the med's composition. What is a generic name? The manufacturer who first develops the drug assigns the name, and it is then listed in the U.S. Pharmacopoeia. What is a trade name? Also known as brand or proprietary name. This is the name under which a manufacturer markets the medication. What is a therapeutic effect? Expected or predicted physiological response. How do we classify drugs? Effect of med on the body. Symptoms the med relieves. Med's desired effect. What is an adverse effect? Unintended, undesirable, often unpredictable. What is a side effect? Predictable, unavoidable, secondary effect. What is a toxic effect? Accumulation of medication in the bloodstream. What is an idiosyncratic effect? Overaction or underreaction or different reaction from normal. Can we delegate med admin? No. Okay. Talk about type of orders. We got standing or routine orders. You got single orders, which is one time for specific reason. Now, which is required, needed right away, but not stat. So like within 1 hour. We got PRN is as required. Stat is immediately within 30 minutes. Stuff like that. Okay. What are the 8 rights of med admin? Right med, right dose, right patient, right route, right time, right documentation, right reason, right response. We have to maintain a patient's right. So a patient has a right to be informed about the med, to refuse a med, to have a med history, to be properly advised about the experimental nature of the med, to receive labeled meds safely, to receive appropriate supportive therapy, to not receive unnecessary meds, to be informed if meds are part of a research study. So, medication errors. Report all med errors. Patient safety is the top priority when an error occurs. Documentation is required. RN is responsible for preparing a written occurrence of incidents report, an actual factual description of what occurred and what was done. RN plays an essential role in med reconciliation. Alright, oral meds. We know the easiest and most desirable route. How do we give oral meds? Sublingual and buccal. Oral meds, you give meds with food if needed for better absorption. Often give with 60 to 240 milliliters. Proper positioning to prevent aspiration. When administering, 1+ med, give each separately, and flush with 15 to 30 milliliters of water in between each med. When given on an empty stomach, make sure patient doesn't eat 30 minutes before or after med administration. Enteral meds are like NG tube, G tube, J tube, or small bore feed tubing. Keep the head of a bed elevated at least 30 degrees for 1 hour after med. All right, topical meds. Tell me about topical meds. You're going to use gloves and applicators. You're going to clean the skin first. Use sterile technique if applying to open wound. What about transdermal patches? Remove old patch before applying the new patch. Document the location of the new patch. Ask about patches during medication history. Apply a label to a patch. If it's difficult to see, document removal of the patch as well. Wait 1 week before applying a new patch to the previous site. All right, tell me about nasal spray meds. How are we going to position them? Sit upright, occlude one nostril, tip head forward, spray, sniff, and swab. What about nasal drop meds? How are we going to do that? For maxillary and frontal sinuses. Head over edge of bed and tilted side to side. How are we going to get the ethmoid and sphenoid sinuses? Head over edge of bed and straight back. All right, what do we need to know about eye meds? All right, avoid the cornea. Avoid the eyelids with droppers or tubes to decrease the risk of infection. Use only on affected eye. Never share meds. We got intraocular installation. Disc resembles contact lens. All right, what do we know about ear meds? Instill at room temperature to avoid vertigo and use sterile solutions. Pull pin it down if it's a child and up if it's an adult. Check for eardrum rupture if patient has drainage, and never occlude the ear canal. What do we know about vaginal and rectal installation? Suppositories use left lateral Sims position. You're going to lube, push point first, past anal sphincter, push against wall, not in center against feces, and let it absorb. They will melt. All right, inhalation meds. What are their pressurized meter dose inhalers? Needs sufficient hand strength and hand-eye coordination, may be used with a spacer. What about breath-actuated meter dose inhaler? Depends on strength of patient's breath. What about dry powder inhalers? Activated by patient's breath. All right. What are irrigation meds? Cleanse an area, instill a med, or apply hot and cold to injured area. Most commonly uses sterile water, saline, or stuff like that. Use aseptic technique if there's a break in the skin or mucosa. Use clean technique when the cavity to be irrigated is not sterile, as in the case of the ear canal or vagina. All right. Lure lock needles are twisted on the tip and lock themselves in place. Non-lure lock needles slip onto the tip. All right. Needle has the hub, shaft, and bevel. All right. Ampules, single doses of med and lipo. So to prepare an injection from the ampule, I'm going to use alcohol prep pad and snap off the ampule neck away from you. Put it on a flat surface. Aspirate med into syringe using filter needle. Replace filter needle with appropriate size needle, and then administer injection. All right, a vial is a single or multi-dose container with a rubber seal on top, liquid or dry meds. A closed system in a vacuum, and air needs to be injected into it to permit easy withdrawal. Use friction to get vial clean with alcohol prep wipes. Med is dry, use solvent or diluent as needed. Inject air into vial. Label multi-dose vials after mixing and refrigerating remaining doses needed. So mixing meds, a vial plus ampule. Prepare med from vial first. Use the same syringe and feed the needle to withdraw the med from the ampule. Vial to vial. Don't contaminate one med with another. Ensure final dose is accurate and maintain aseptic technique. Insulin is U500 or U100. Clear to cloudy when mixing insulins because you can't see through the cloudy. Don't shake insulin vials or bubbles before form. Roll through hands. Administered by injection because the GI tract breaks down and destroys oral insulin. Never mix insulin glargine or Lantus or insulin determer or Levemir with other types of insulin. Inject rapid-acting insulins mixed with NPH. Insulin within 15 minutes before a meal. Verify insulin doses with another nurse while preparing the med. Minimize patient discomfort with injections. Sharp bevel needle in the smallest suitable length. Engage position patient comfortably. Select proper injection site. Apply a vapocoolant spray or topical anesthetic. Divert patient's attention from injection. Insert the needle quickly and smoothly. Hold the needle steady while the needle remains in tissues. Inject med slowly and steadily. Sub-Q is loose connective tissue under the dermis. What do we know about subcutaneous injections? Slower absorptions than IM. Best sites are outer posterior aspect of our arm, abdomen, and interior thighs. Got to make sure they're free of skin lesions, bony prominences, and large underlying muscles and nerves. If you can grasp 2 inches of tissue, insert at 90 degrees, but if you only get 1 inch, 45 degrees. So adults are going to get 2 to 5 milliliters. Children / older adults / thin patients, 2 milliliters. Small children and older infants, 1 liter, and smaller infants, 0.5 milliliters. All right, IM. It's faster absorption because of greater vascularity. Many risks, so verify injections needed. Needle longer and heavier. Angle of insertion is 90 degrees. You got ventrogluteal, vas lateralis, and deltoid. Ventrogluteal, that's the gluteus medius. The deep, preferred, and safest site for all adults, children, infants. Recommended for volumes greater than 2 milliliters. So index finger on the middle, and index finger, middle finger, and iliac crest form a V shape. Triangle. Insertion site is the center of the triangle. Then you got vastus lateralis, used for older adults and children. Use middle third of the muscle, often used for infants, middle and deltoid. Okay, don't aspirate for immunizations to reduce discomfort. And then use the Z-track method. It's a zigzag path, seals needle track, used with meds that may be caustic to skin or underlying tissue, or meds that need to stay in the muscle and can't come out. Intradermal is for skin testings like TB or allergies, so the sites are inner forearm and upper back, angle 5 to 15 degrees, bevel pointed up until small blood appears. So IVs, mixtures with large volumes of fluid, safest and easiest method, 5 to 1,000 milliliters used. If infused too rapidly, patient at risk for overdose and fluid overload. So IVs by injecting a bolus or small volume via IV and or heparin lock. Introduces a concentrated dose of medication directly into systemic circulation. Advantageous when the amount of the fluid a patient can take is restricted. The most dangerous method for med admin because no time to correct errors. Crazy. Volume controlled infusions. Use small amounts, so like 50 to 100 milliliters of compatible fluids. 3 types. You got volume control administration, piggyback, and syringe pumps. Advantages. Volume controlled infusion. You got reduces the risk of rapid dose infusion by IV push. Allows for admin of medication that are stable for a limited amount of time. And allows control of IV fluids. Volume control admin. Small 150 milliliter containers that attach just below the primary infusion bag or bottle. Syringe pump, battery operated, allows meds to be given in very small amounts of fluid, 5 to 60 milliliters in controlled infusions. Times using standard syringes, meds given very slowly. Then you got the intermittent venous access saline lock. Good things there. This shit's trash. This chapter was fucking trash. Okay. All right, what is a fluid balance? Normal intake and output, decreased intake and output, increased intake and output. What is the thirst control mechanism located? Hypothalamus. What stimulates this thirst control mechanism? Stimulated by increased plasma osmolality, decreased plasma volume, angiotensin 2 and 3, dry pharyngeal mucous membranes, and psychological factors. All right, what organs in the body control fluid output? Skin, lungs, GI tract, specifically the colon, and kidneys. What influences fluid output? ADH, RAS system, and ANPs. What is sensible water loss? You can see it like sweat. What is insensible water loss? You can't see it like breathing out. All right, what percent of total body water? All right, what is the percentage of body weight of total body water? 60 liters. What percentage of that is intracellular? 65%. What percentage of that is extracellular? 35%. What percent of the extracellular fluid is plasma fluid? 7%. What percent of the extracellular fluid is interstitial fluid? 28%. Cation, sodium, potassium, calcium, magnesium, anions, chlorine, and bicarb. Okay. All right, what are the symptoms of hyponatremia? Stupor, coma, anorexia, lethargy, decreased tendon reflexes, limp muscles, orthostatic hypotension, seizures, and stomach cramps. What are the signs and symptoms of hypernatremia? Low-grade fever, high blood pressure, fluid retention, edema, decreased urine output, increased tendon reflexes, and muscle spasms. What are the symptoms of hypokalemia? Alkalosis, shallow respirations, irritability, weakness, arrhythmias, and weak pulse. What are the symptoms of hyperkalemia? Muscle cramps, respiratory distress, chest pain, dysrhythmias, and oliguria. What are the symptoms of hypercalcemia? Convulsions, arrhythmias, tetany, stridor, and spasms. What are the symptoms of hypercalcemia? Bone pain, high heart rate, cardiac arrest, kidney stones, muscle weakness, polyuria. What are the symptoms of hypomagnesemia? Increased tendon reflexes, seizures, muscle cramps, tremors, and tachycardia. What are the signs and symptoms of hypermagnesemia? Muscle weakness, lethargy, bradycardia, decreased respirations, and hypotension. All right, what's the normal amount of fluid intake in a day? 2,300 milliliters. What are some ECF imbalances involving fluid volume and osmolality? Osmolality imbalances are hypernatremia / water deficit / hypertonic, and hyponatremia / H2O hypotonic. Clinical dehydration is ECAV deficit and hypernatremia combined. Holy fudge. Osmolality is the measure of the number of particles per kilogram of water. Isotonic is 0.9%, hypotonic is 0.45%, hypertonic is 3%. In the blood, sodium mostly determines osmolality. All right, what foods can we get phosphate from? Milk, processed foods, cheese, meat, seeds, canned fish. What is the function of phosphate? ATP production. What foods can we get potassium from? Fruits, potatoes, instant coffee, molasses, Brazil nuts, spinach, beans, fish. What are the functions of potassium? Maintains resting potential of skeletal, smooth, and cardiac muscles. What foods can we get calcium from? Dairy products, broccoli, leafy greens, oranges, seafood, dried fruits, meat, beans, soy, almonds. What is the function of calcium? Influences excitability of nerve and muscle cells, muscle contraction. What foods can we get magnesium from? Dark green vegetables, whole grains, avocados, bananas, nuts, legumes, dark chocolate. What is the function of magnesium? Works at neuromuscular junction, cofactor for enzymes. All right, what are some of the physical assessments we can do for F&E? Daily weights, INO, labs, vital signs, stuff like that. All right, is dextrose 5% isotonic, hypotonic, hypertonic? Isotonic. What about dextrose 10%? Hypertonic. What about 0.225% NaCl? Hypotonic. What about 0.45% NaCl? Hypotonic. What about 0.9% NaCl? Isotonic. What about 3 to 5% NaCl? Hypertonic. What about dextrose 5% and 0.45% NaCl? Hypertonic. What about dextrose 5% and 9% and 0.9% NaCl? Hypertonic. What about lactated ringers? Isotonic. What about dextrose 5% and LR? Hypertonic. So too rapid or excessive infusion of any IV fluid has the potential to cause serious problems, especially be careful of potassium infusions because they may cause arrhythmias or death. You document site of insertion, number of attempts, flow rate, method infusion, size and type of catheter, time infusion started, patient's response to insertion. Monitor for problems, phlebitis, infiltration, extravasation. What is phlebitis? Damage to the vein itself causes red streak down the arm. What is infiltration? Leakage of fluid out of the vessel causing edema and redness. What is extravasation? Leakage of the vesicant medicine out of the vessel causing tissue damage. All right. What is tissue integrity? The state of structurally intact and physiologically functioning epithelial tissues such as the integument and mucous membranes. What is the epithelium? Tissues that line cavities and structure surfaces throughout the body. What is debridement? Removal of dead, damaged, or infected tissue. What is granulation? Connective tissue that forms on the surface of a healing wound. What is turgor? Elastic state of skin and tissue. What is an emollient? Agents that soften skin and treat dry skin. What are the risk factors of tissue integrity? Can occur in all individuals, but infants, children, older adults are the greatest risk. So poor peripheral perfusion, malnutrition, obesity, dehydration, edema, impaired mobility, immunosuppression, exposure to chemicals, and tissue trauma. What are some prevention measures for tissue integrity? Skin hygiene, adequate nutrition, avoidance of excessive skin exposure, burn safety precautions, and dermal ulcer prevention. What's a first-degree burn? Partial thickness injury involving epidermis, normal skin barrier remains intact. What is a second-degree superficial particle thickness injury? Thin-walled, fluid-filled blisters develop within minutes of exposure. What is a second-degree deep partial thickness injury? Involves entire dermis, appears waxy, white, and surrounded by superficial partial thickness injury. What is a third-degree burn? Full thickness injury, destruction of epidermis, and often underlying subcutaneous tissue, bone and muscle may be destroyed. Wound appears dry and leathery. All right, so the rule of 9 for burns. What is the percentage for the head? 9%. Chest and abdomen? 18% upper, mid, low back, and buttocks, 18% each arm, 9% groin, 1% each leg, 18% total. A, B, C, D, E, asymmetry, melanoma is asymmetrical, irregular, color, diameter, evolving. All right, pressure ulcers, reposition every 2 hours. If you don't have muscle support, you may end up with tissue damage. Risk factors for pressure ulcers: impaired sensory perception, impaired mobility, altered LOC, shear, friction, and moisture. Was a stage 1 pressure ulcer. Intact skin with non-blanchable redness. Coloration may be cooler or warmer than adjacent tissue, painful and firm. Was a stage 2 pressure ulcer. Partial thickness skin loss involving epidermis, dermis, or both. Wound bed is viable, pink, red, and moist. Granulation tissue, slough, and eschar are not present, but a serious as sanguineous fluid-filled blister may appear. Was a stage 3 pressure ulcer. Full thickness tissue loss with visible fat and granulation tissue, and often epibole by rolling inward of the wound edges. Tunneling and undermining may occur. What is a stage 4 pressure ulcer? Full thickness tissue loss with exposed bone, muscle, or tendon. Slough or eschar may be present, often has undermining. Was a deep tissue injury. Purple or maroon, localized area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure and or shear. What is an unclassified pressure ulcer? Has eschar on it. You may not be able to tell how deep it is. It will be stage 3 or 4 when the eschar is removed. What is a partial thickness? Burn, I think. Partial thickness healing wound. Partial thickness wound. Shallow in depth, moist and painful, and the wound base generally appears red. Was a full thickness wound. Extends into the subcutaneous layer, and the depth and tissue vary based on location. What are the benefits of gauze dressings? Thin, transparent fabric. Apply as moist dressing with saline or dry dressing with enzymes or topical antibiotics. Deliver moisture and is absorptive. Tell me about transparent film dressing. Traps wounds moisture over the wound, ideal for small superficial wounds, can remain in place for up to 5 to 7 days, allows visual assessment of wound bed without removing dressing, wound must have minimal to no exudate, maintains moist environment and offers protection. Tell me about hydrocolloid dressing. Maintains moist environment to facilitate wound healing while protecting wound base. Used for pressure ulcer stage 2 or 3. Tell me about hydrogel dressing. Gel used to regulate fluid exchange and relieve pain during wound healing. Can be covered with foam. Maintains moist environment. Used in pressure ulcer stages 2 to 4. Tell me about calcium alginate dressing. Used with large amounts of exudate. Packed in the wounds, turns to soft gel. Exudate is highly absorbed. Requires secondary dressing. Used for pressure ulcers stages 3 to 4. Tell me about foam dressing. Protective and prevents wound dehydration. Absorbs moderate to large amounts of drainage. Can be used in combination with hydrogel. So Braden scale, prevention stuff. Factors influencing wound healing are going to be nutrition, tissue perfusion, infection, age, and psychosocial impacts of wound healing. What is a primary intention healing? What's primary intention wound healing? Wound edges are approximated, such as like a surgery. Risk of infection is low. Healing occurs minimally. Low scar formation as long as infection doesn't occur. Tell me about secondary intention wound healing. Like a laceration, carpet burn, or pressure injury, risk for infection is high. Scar tissue takes a long time to form. It doesn't have perfusion. Tell me about partial thickness wound repair. Inflammatory response, epithelial proliferation and migration, and establishment of epidural layers, just like a scrape or abrasion. Tell me about full thickness wound repair. Homeostasis, inflammation, proliferation, and epithelialization. Alright, then we got like a hemorrhage, complications of wound healing like hemorrhage, maybe infections, dehiscence, wound burst open, eviscerations, wound opens up, but then the organs come out too, which is crazy. So you want to begin by putting saline soaked gauze in the wound and then preparing to send the patient back to surgery. Alright, pressure ulcer, stage 1, what is the status of this? It's intact. What dressings would you use for these? None, transparent dressing, or hydrocolloid dressing? Why would we use no dressing? Open to air and allows visual assessment. Why would we use a transparent dressing? Protects from shear infection. Why would we use a hydrocolloid dressing? For more serious wounds, that keeps wound moist but doesn't always allow for visual assessment. So it should resolve slowly without epidermal loss in 7 to 14 days. What are some interventions for stage 1 pressure ulcers? Turn patient, hydration, nutrition, pressure redistribution, chair with the cushion. All right, stage 2, what is the status of that one? Clean. What dressings are used for stage 2? Composite film, hydrocolloid, hydrogel. Why would we use a composite film? Prevents shear and friction but can't see it. Why would we use a hydrocolloid dressing? Change when seal dressing breaks. Max wear time is 7 days. Why would you use a hydrogel? Moist environment. So it heals via reepithelialization. Stage 2 do. What are the interventions for it? Turn patient, hydration, nutrition, pressure redistribution, chair with the cushion, manage incontinence. All right, what's the status of a stage 3 pressure ulcer? Not intact but clean. What dressings would you use for this? Hydrocolloid or hydrogel covered with foam, and then calcium alginate. Why would you use a hydrocolloid? Change when seal is broken. Why would you use hydrogel covered with foam? Used when there's significant exudate covered with secondary dressing. Why would we use calcium alginate? Wound has lots of exudate covered with another dressing. Could also use gauze. Why would we use gauze? Unfolded to make contact with wound and soaked with saline gauze. And we can use growth factor with gauze. So wound heals via granulation, epithelialization. So you're going to turn patient, hydrate, nutrition, pressure distribution, chair with the cushion, and manage incontinence. All right, what's the status of a stage 4 pressure ulcer? Clean wound. What are the dressings you'd use? Hydrogel covered with foam, calcium alginate, and gauze. All right, so it heals via granulation, scar tissue formation, reepithelialization. You may need a surgical consult. All right, unstageable pressure ulcer. What is that status? Wound covered with eschar. What dressings would you use? Enzymes, adherent film, gauze plus ordered solution, and none. Why would we use enzymes? Break down eschar and provide debridement. Why would we use adherent film? Softens eschar. Why would we use gauze plus ordered solution? Delivers solution and wicks wound drainage. Why would we use nothing? If eschar is dry and intact, no dressing is used, allowing eschar to act as a cover. So eschar lifts at edges as healing progresses. Eschar loosens over time. You may need a surgical consult. So you're going to assess the skin. Blanchable erythema gets white when you put pressure on it. Non-blanchable erythema does not turn white when you put pressure on it. Pressure injuries, the wounds, goals and outcomes. You want to see the wound heal in 2 weeks. Implementation stuff. Homeostasis, cleaning, no hydrogen peroxide, changing dressings, maybe give pain meds 30 to 60 minutes before dressings, easy peasy, no hydrogen peroxide, cleaning, clean to dirty, gentle friction, drainage, easy peasy.